Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Today we have a special guest from Australia on our first podinar of the day, Dr. Derek Mahony. Dr. Mahony, thank you for joining us.
Thank you. It's my pleasure.
I've been personally looking forward to this podinar. It's 7 years I've met you in New York, and you were the guy in the room everybody was surrounding. And I was wondering who you were. And then after talking to you and walking up to you, you let me know that you're from Australia and you're an orthodontist. And later I got to find out that you are everywhere. Thank you for joining us. It's quite an honor. Our audience is from all around the world. And I'd like to take a minute to introduce you to them so they have an idea who you are. So the topic today that relates to pediatric dentistry as well as orthodontics and sleep apnea makes a little bit more sense. So in a short scenario fit, Dr. Mahony is a specialist, an orthodontist who has been in private practice for over 30 years. He has built his practice, clinical teaching, and a worldwide reputation in offering early and receptive orthodontic treatment. He's invited reviewer of many dental journals. I've seen him as an editor in many of them, or a guest editor or something similar in the field of facial development and its association with nasal breathing. He has been involved in leading research linking maxillary arch expansion to reducing a number of systemic disorders such as bedwetting and ADHD. It'll probably take me all day to read his credentials, but in short, a BDS, an orthodontist degree, London, Eden. He's been recently actually finished his PhD in this very topic, and the titles go on and on: FICD, IBO, FACD, FIADFE, which met you. That's where we met you at the annual event, and on it goes. So in Sydney, and he lectures all across the world. Actually, he's frequently in the US and UK and other places. And he does different studies, actually, with the Royal College of Surgeons in Edinburgh. You guys, most of you know this particular school system. Royal College of Physicians and Surgeons. And he has treated over 3,000 orthodontic patients and is frequently a keynote in the orthodontic space, but now soon more also in the pedo space. Doc, you are also an editor of Clinical Pediatric Dentistry and National Journal of Orthodontics and the Spanish Journal of Dentofacial Orthopedics. So my first question before we start the session, where do you take all this time? Where does the motivation come from?
I love what I do. I mean, I was never a good general dentist. I can tell you that. Like, I think I did one root canal in my life and created a few extra canals. You know, I kind of just sucked at that. But when I got into orthodontics, I really realized my passion, particularly in interceptive care. So what drives me is, getting these young kids, not just with straight teeth, but getting them healthier, getting them sleeping better. That's the real drive.
Excellent. Sleep apnea is an important scenario. I do a lot of full mouth rehabilitations where we raise the bite and open up the airway and deprogram the muscles. But I presume it's going to be a lot more complex on a child. And we'll learn how to do that with expansion, probably extrusion. You're going to tell us how you do it.
Correct.
So how is compliance with a pediatric patient when you try to do these kind of procedures?
Yeah, so all the appliances that we've developed to make the maxilla the right dimension, right position, and mandible to match, most of them are fixed in the mouth. So I think compliance is good because the kids can't take it out. I think there's worse compliance with kids having to wear CPAP, which up till now was the main form of treatment for these kids, because that becomes a bit of a compliance issue, and the ability to wear the mask with a young growing face, et cetera, et cetera. Yeah, we have very good compliance in this regard.
Excellent. So a fixed appliance certainly will be more beneficial. We're doing a lot of these appliances also for adults that are on CPAPs and come in with a sleep study and such.
Yeah.
So yes, but the ones where it works for them, they're very happy with them versus their CPAP. So how many journals? I mean, are you actively publishing a lot of work on this topic? What are you doing with it?
Yeah, so we dissected so many things in this. The research took me over 15 years, so it's a lot of data. We're looking at nearly 4,000 patients, and we measured everything in these kids: their sleep, their malocclusion type, the width of their palate, the depth of their palate, where their hyoid bone was. So literally, there's a paper almost on everything we measured, and it all comes to the same thing that. A dentist, if they just understand a few screening tools, like the width of the palate, like the position of hyoid bone, if they take a lateral ceph, looking in the mouth and looking at signs such as large tonsils, et cetera, et cetera. The dentist really is the gatekeeper of diagnosing this problem. Now, in Australia, and I'm sure in the US, it's a medical condition, so the proper diagnosis, particularly for insurance, has to be by a medical doctor. But the dentist can can do the screening and send the patient for the sleep study that then ultimately leads to the diagnosis. So I guess in this lecture, I'm going to tell dentists what sort of things that they'll see in these kids to alert them to maybe get a sleep study done. And then once you tell the parent the problem, it all makes sense. And once the kid is improved in their sleep, the parents say things like, Dr. Mahony, thank you so much for giving me back a different kid. These kids are hyperactive because they're not sleeping well. Their cognitive performance is not good, so they're in the bottom part of their class. And they're just those sort of disruptive kids that we all come across, but no one's really been able to put a finger on why. This research, I think, leads us to understand that poor sleep in a child affects their facial development, but also their performance at school and the way they act. So I think it's a big wake-up call for dentists to realize that when they're treating a malocclusion, they're actually also probably treating an airway problem.
Airway problem, behavioral problem. Very interesting. Yep. Very interesting. What sort of behavioral problems have you heard of or noticed or got feedback for?
The big one is ADHD, which is often misdiagnosed because the kid's disruptive, and it's normally the teacher at school driving this. They don't want a disruptive kid in the classroom, and so a lot of these kids are put on Ritalin. And if you understand that over 50% of these kids actually don't have true ADHD, what they have is poor sleep, and the Ritalin actually affects their sleep even more. So they get on this cascade that they can hardly come off. If you go to YouTube, there's a fantastic little story on a kid like this. It's called Finding Connor, and I have a reference during the lecture. But it shows exactly this type of kid and how the parents had great relief once someone actually took the time to ask the right questions. Does your child snore? Do they sleep with their mouth open? Et cetera, et cetera. And from that, got the sleep study and got the appropriate treatment for the kid.
It's quite amazing. That's quite amazing to have also those kind of effects come in as a result of this treatment. So where does one get started, Doc, to look into this protocol? I'm sure you're going to explain it a little bit more for us. We're going to leave your contact information on the side if anybody has any particular questions. Yep. And enjoy this presentation. And congratulations also on being elected as the 2021 World's Top 100 Doctor, which you have an amazing class coming together with some of the many of the leaders that are actually your friends and colleagues that you know. So more on that soon, but we also look forward to having you in 2021 on a podium. And meanwhile, other than that, I'm very excited to hear your lecture, and we're gonna go ahead and give you the floor. Thank you so much, Doctor.
Thank you. Thanks very much for the introduction and the invitation to speak. So, well, it's good morning from me here, but I understand, Dr. Shah, that there are people tuned in from all around the world. And I mean, it's a big topic to cover in such a short time. So what I'm going to do is just give you a bit of an overview. And for more depth, if you email me, I'm happy to send you all the papers. I have like a Dropbox link that has my slides, the papers, the forms you need, such as Bear's questionnaire to give to parents to kind of screen for this problem, and also my protocol. And remember, just to give you an idea, when I ask a dentist, is sleep disorder breathing common in the kids that he's treating? Number one, the dentist will probably say, look, I don't know what sleep disorder breathing is. And number two, in dental school, we really aren't trained to look for the signs and symptoms associated with this. And many of the signs and symptoms are in the mouth and around the face. So it's something that we as dentists and orthodontists and patients doing, doctors doing dentofacial orthopedics should be familiar with, right? So what are some of the common things that you'll see in these kids? Grinding their teeth at night. We're talking about 4-year-olds, 5-year-olds, 7-year-olds with extreme bruxism. And, we have adults who have extreme bruxism, and there's various theories on that, but a lot of people relate that to stress. More and more research coming out of University of Montreal with Professor Gilles Levine is showing that a lot of bruxism at night in adults is really called sleep bruxism. And what it is, it's the body's way of triggering the airway when you have a micro arousal. And this is for you guys who I believe do a lot of implants in your study group. It's something to be aware of, that if you're putting 5, 6, 7, 10 implants in someone who bruxes that heavily, it would be a good thing to find out why they brux. And if you can stop them bruxing, then that would help the longevity of your implants. But when it comes to kids, you can snore and not have sleep apnea as an adult. But with children, there's a much higher comorbidity between snoring and sleep apnea. So again, one of the questions you should ask the parent, does your child snore? And again, the answer would probably be, I don't know. He hasn't slept in my bedroom for years. He sleeps down the hallway and we can't hear him. So you can download on any smartphone an app that's free. It's called Snore Lab. And it picks up very accurately labored breathing, snoring, stop breathing, et cetera, et cetera. So it's not a sleep study, but it's a great free screening tool to tell that whether the patient is breathing heavily at night. Now, the other thing that we ask is, how's your kid going at school? What's their concentration span like? They're not paying attention. Do they wake up in the morning with frequent headaches? During the day, do they suffer from migraines? And more and more now, we're seeing that these kids who mouth breathe tend to have oxygen desats. And a very simple tool, tool number one is just ask the right questions and give the patients a paediatric screening questionnaire. I use the Bear's questionnaire, but there's a number of others on the market. Number two is to send the kid home with a very simple LED pulse oximeter. And these new ones literally just go on the finger or around the wrist, and they're very comfortable for kids to wear. And then that data you can look at with the software that comes with this machine, and it tells you whether the kid is dropping their oxygen saturation because of this problem. But the true diagnosis, and what we did in our PhD, is we put these kids in an overnight hospital-based PSG, which is a full level 1 sleep study. And that way we were able to measure a number of things, and I'm going to go through the definition of that. So these are the things that we were measuring in these kids. Now remember, these are children who were referred to me not because they had disruptive sleep, not because they were not doing well at school, but because they had a malocclusion. At the end of the day, my initial training is as an orthodontist. So my referral base is still largely for bad bites, crooked teeth. But I've developed a reputation in the community that most of my referrals now come from ear, nose, and throat doctors, pediatric sleep physicians, etc. So we couldn't, for the sake of bias in my PhD research, include kids referred specifically for poor sleep. So I included in my data kids referred to me between the age of 7 and 9, just for malocclusion. And because I examined the mouth and realized that there was a commonality to the malocclusion type and what's called sleep disordered breathing, we went on, and other than take just orthodontic records, we also put these kids through a sleep study. So what is obstructive sleep disordered breathing? It's a syndrome of upper airway dysfunction during sleep, and it's characterized by snoring and or increased respiratory effort. And these factors result really from increased upper airway resistance and pharyngeal collapsibility of the airway, both at the level of the nose, at the level of the palate, at the level of the oropharynx, which is where we look at in the mouth. And you could have a kid who just snores, you could have a kid who just mouth breathes as a simple clinical entity. And then as it gets more severe, you get to the dangerous one where the kid has recurrent events of partial or complete airway obstruction, which is what we call hypopneas or apneas. And they're the dangerous ones because that's when there's a disruption of the kid's normal oxygenation, their ventilation, and of course their sleep pattern. So I guess you've all seen the kid on the left. She has a raging class 2, a very narrow palate. When I ask her to bring her jaw forward, as you see in the second diagram where my cursor is, you can see that her upper jaw doesn't fit her lower jaw, but when she occludes, her lower jaw so far back because of the narrowness of the upper jaw. So if you look at her profile, her mandible is way back from where it should be, and one of the causative agents of that is her narrow maxilla. Now, I'm just hoping that if I play this video, it'll work. I'll try it. This explains exactly what causes this.
A normal upper arch should look like this. It forms that way because the tongue rests in the area between the upper teeth. There, it counteracts the pressure of the cheeks, which would otherwise push the upper arch of the jaw in. But if a child sucks his thumb or breathes through his or her mouth for any reason, then the tongue drops from the top of the mouth and the upper arch can get pushed in. The narrowed upper arch has a knock-on effect on the lower jaw, forcing it further back and down.
And that video actually comes from a 60 minutes documentary we did on this topic. And I'm happy to send the link for that. It's a good one for parent education. So the girl on the left is 7, and at that age, it's easy for me to develop her maxilla and encourage her lower jaw to grow forward because most of her facial growth is occurring between 7 and 9. The boy on the right, he's the classic orthodontic age. He's 12. He has all his adult teeth, but you can see he has the same facial type, narrow jaw and narrow upper jaw and recessive lower jaw. And look at the degree of crowding. But the question we have to ask ourselves is what has caused that crowding? What has caused that crowding is not genetics. It's not the simple, my dad has big teeth and my mum has small jaws, the sort of thing I was taught in dental school. What's actually caused that crowding is his mouth breathing. He's had nasal obstruction in the form of allergic rhinitis throughout his life. And because no one's picked that up early, he's continued to develop this very long face and this constricted maxilla, because as that video showed, the tongue's not doing its job in the palate, so the buccinator is pushing everything together. And of course, at that age, it's much harder to treat, and the majority of my colleagues would camouflage the problem by just addressing the dental crowding, which would mean they'll take out 4 premolar teeth, put braces on, give the kid straight teeth, but by taking teeth out, they're actually worsening the narrowness of the palate. So the real problem is not being addressed. Now, luckily for people at that age, you can still develop the palate using newer techniques, and in particular, a technique that was researched and developed at UCLA by Professor Won Moon, and it's called MSE. And maybe in a future podcast, I'm happy to go through that. So it's not as though I just still take teeth out of this kid and tell the kid it's unfortunate you didn't come in at 7. I can still treat him, but it's much harder work. Alternatively, I can wait until he, like this girl, turns 21, and then we can perform a bimaxillary advancement osteotomy. And I want you to see that this girl, her profile is the same as the young girl and the teenage boy. They are class 2 long. What does that mean? It means that their upper jaw is narrow, their lower jaw is set back. And the treatment for this involves expansion, or at this age, at least for this girl, surgical expansion of the maxilla in the form of a Lefort, and then an advancement of both the maxilla and mandible, plus or minus a genioplasty. So obviously the girl looks better, but she didn't come in because she was worried about her facial appearance. She came in because she had severe sleep apnea and couldn't cope with a CPAP machine. So I always say to parents, if you can pick up this problem early, what you're able to do is identify the concern, look at the sleep, and then actually change the jaw position, which actually structurally makes it harder for these tissues to collapse. So this girl on the left is ideal age for treatment. The boy on the right is not, neither is she. So if we look at that same facial type, and it's what we call a class 4. What is a class 4? Class 4 is a term we've coined because it's the most identifiable problem in these kids. And it is a maxilla that's back, a mandible that's further back, and a long face, such as this girl here. Now, this girl, she's had improved facial growth because she's had the corrective treatment at the right time. One of my colleagues in the United States, Dr. Karen O'Rourke, who was trained by Dr. John Mew, has come up with this little booklet. I don't know if you're going to see that on the screen there, but you can email me and I'll put you in touch with her. And basically, it's the booklet's called Early Screening for Dentofacial Growth Problems, and it uses a simple tool, which is a ruler, that allows us to see where exactly that maxilla is and where it should be. And I teach this all around the world. This is one of my students, and he sent me this the other day because I taught him about bruxism in kids. And when he saw a young child who had this problem, he made the right call. He referred to an ear, nose, and throat because the major cause of bruxism in children is upper airway obstruction in the form of adenoids and tonsils. And the kid had the appropriate treatment. So you can see that the parents are ecstatic because they noticed that the child's behavior and his performance at school improved after this. I think, I'm a happy guy when we get these little messages, right? Now, just give me 1 second. I'll just turn the background light off. All right, that's better, hopefully. Yeah, so this is one of the first papers from my initial research. When I graduated from orthodontic school in London, I spent some time researching at the Karolinska Institute in Stockholm in Sweden. And my supervisor was Sten Linde Aronson, who was doing an amazing study where he looked at children who had large adenoids and he compared them to kids who were normal nasal breathers. Then he showed that these children who couldn't breathe properly developed what's called an adenoid face, which is effectively what I'm showing you, the class 2 high angle malocclusion. And medical doctors refer to this facial type as characteristic of a mouth-breathing child with a long anterior face and a retrusive mandible. And the theory that Linda Aronson had used for his long-term research is that the nasal obstruction resulting multiple causes ranging from, you can see here, the adenoid pad or the tonsil to nasal stenosis, large inferior turbinates, etc. But that habitual mouth breathing alters the facial and muscular force vectors on that developing craniofacial skeleton. And that potentially leads to long-term changes in the morphology. So as a result, those children develop a long anterior face with retrognathia, whereas what they should have is forward growth. So you can see this girl, her backward growth has been converted into forward growth. And we published this in the Australian Orthodontic Journal back in 2004. And when I did my literature review for my PhD, we read hundreds and hundreds of papers. And what I soon realized that this was nothing new. It was new to me because I was never exposed to any of this in orthodontic school, let alone dental school. But when I look back at the precursor of JADA, which is called the Dental Cosmos, what do I find? I find in 1909, there's an article in the journal which talks about habitual mouth breathing and its consequence on the malocclusion of the teeth. And this was interesting to me because right now, no one had been saying, well, the reason your kid has a malocclusion is because they mouth breathe. Everyone was talking still about the genetic aspect of malocclusion rather than the epigenetic, which I think is the truer cause. And back in 1909, they were talking about mouth breathing and its relation to dentistry and also how you could treat it early. This is over 100 years ago. And they're saying you should develop a close alliance as a dentist or orthodontist with a ear, nose, and throat doctor. And some of the signs were chin receding, roof of the mouth being high, dental arches being contracted, i.e. more malocclusion. But look at the big one on the bottom right in the diagram. Teachers will accuse children of being inattentive at school. So really, this is well before someone had thought about ADHD. So if you're a dentist and you're seeing this narrow palate, this mouth breathing, the class 2 forming, the kid not doing well at school, you can't just fissure seal the kid's teeth and put fluoride in there, take a bite wing and book them back in for a 6-monthly recall because, I would call that supervised neglect because you're missing the growth opportunity of changing this patient's life. And again, a paper here by Glenn Bowman, 1909, where they talk about if you don't do something early and you wait and wait and wait, which is what I was taught to do at orthodontic school, wait until adult dentition, it talks about brain development being retarded. And if you look at the excellent research by Dr. Gozal in Chicago, he has mapped out with MRIs the frontal lobe in kids who have poor sleep compared to those who are normal. And he's shown definite drops in IQ on these children every year that they're not picked up early. So, just digressing, that nasal obstruction, its consequent mouth breathing has been around for a while when it comes to dental malocclusion. And back in 1909, they were saying that early diagnosis and treatment should be done for the common good of humanity. This is what led me into my long-term research, which I did through University of Barcelona, one of the oldest and most respected dental schools in Europe. And the reason I chose that university to do my research is because the head of the department there was Professor von Duron-Arx, and Pepe, as he's affectionately known, was one of the first orthodontists to start looking at this problem in kids and developed a whole series of appliances which we'll call MFS, or Myofunctional Screening Appliances, that taught the kids at an early age to have their lips together, breathe through the nose, put their tongue on the palate. And he showed that a lot of these kids ended up with less need for orthodontic care. What I had proposed then is, like, what can we do in the children who are in a mixed dentition, and how can we improve their sleep? So basically, we looked at nearly 4,000 kids who, as I said, were referred to me for an orthodontic consultation. And the first part of the study was to see, was there a correlation? And if there was, what percentage was there? And, you know, from papers I had read, most of the papers were looking just at sleep apnea, which is the worst of the comorbidities of sleep disordered breathing. And when you read the sleep apnea, it could be 10 to 30%, depending on who you read. No one had really looked at the whole spectrum, like mouth breathing, snoring, upper airway resistance, kids who just were finding it hard to breathe through their nose and didn't have sleep apnea. When you added all that data with a proper sleep study, it was 9 out of 10 kids, so, you know, 90% or greater. So that was the first part of the study. And the second part of the study was to evaluate, well, what treatment would you do for these kids that was most effective? We've known for many years you could just remove the adenoids and tonsils, but what we found is after you remove the adenoids and tonsils, there's still what's called residual sleep apnea. And removal of adenoids and tonsils certainly helps the problem, but it doesn't cure the kid. So we used, in my study, a number of other treatment modalities, which included arch expansion of the palate, mandibular repositioning of the lower jaw, myofunctional therapy. And by looking at all of these, we were able to see what was the most effective. So I think that gives you a bit of an overview. And as I said, we literally measured everything and anything that had been reviewed in the past in the literature. The position of the hyoid bone relative to the mandibular plane. Conclusion, sleep disordered breathing children's hyoid bone was further down and back because of their tongue obstructing the airway. We measure not just the width of the palate, but the depth of the palate. And obviously, the narrower the transverse width and the longer the vertical height, the increased link to sleep disordered breathing. And then, of course, we measured cephalometrically both the upper and lower airway. And I'd like to take this opportunity to thank Professor Maria Villa, who's from Saspesa University in Rome. And she's a pediatrician, and we've got very interested in the concept of treatment of kids who have sleep disordered breathing, /sleep apnea. And in fact, her guidelines are accepted by the European Respiratory Society for effective treatment. And she introduced me to this multidisciplinary care. So not like in Australia, up to the time I started this research, these kids, if they were diagnosed with sleep apnea, were given just a CPAP. And the CPAP works, and it's something they need in the short term, but in the long term, it actually compounds the problem because the CPAP prevents forward growth of the jaw. And what we're trying to do is encourage forward growth of the jaw. So with the help of Dr. Villa, I looked at a number of factors, which was the ear, nose, and throat side of things, the correction of the craniofacial deformity, i.e. the class 2, the narrow palate, etc., etc. But as an orthodontist, what I was good at was the actual orthodontic treatment. So it was multidisciplinary care. These kids were seen by an ear, nose, and throat doctor to rule out airway obstruction. They were seen by me to correct their jaw problems. And then they were followed up with what's called myofunctional therapy, which is the true retention of these kids because it keeps strengthening the muscles that were collapsing when they first came in, right? So to remind you again, sleep disordered breathing is a spectrum of conditions, and they result from structurally narrow airways combined with reduced neuromuscular tone, which increases collapsibility. So by me correcting the structurally narrow airway and by my oral myologist dealing with the reduced neuromuscular tone, we were getting outstanding results, better results than just ear, nose, and throat on its own, certainly better results than just CPAP on its own, because CPAP has a very poor compliance. And that's something that Dr. Kinnar had discussed with me in the introduction to this lecture. So whether it's snoring, whether it's mouth breathing, whether it's true upper airway resistance or true sleep apnea, all of those conditions lead to fragmented, unrestored sleep. And what I've shown is they are also increased health risks, such as ADHD, such as bedwetting, such as IQ, performance dropping. And where I can come in is in the malocclusion. So lots of papers, and as I said, there's over 500. If you're interested, please email me. My email was one of the first slides. It's just info@derekmahony.com, and I'm more than happy to share that with you. In this paper, published in the American Journal of Orthodontics and Dentofacial Orthopedics in 2017, they looked at the relationship between nasal resistance and poor tongue posture, similar to the video I played, and what effect it had in children's malocclusion. And what they showed is that the large tonsils was significant of the anterior tongue posture and the pushing of the lower jaw forward, resulting in the class 3. Whereas in the class 2s, it was more the large adenoids. But of course, there was combination factors in there. So when we look at the cephalometrics of these kids, what we're aiming for ideally is a class 1, which is the diagram on the top left. That's where the upper and lower jaw, where they should be, relates to the cranial base. And you can establish that position early in life because the cranial base, which is a primary growth center, which is from nasio to sella, it actually stops its growth for most kids by 7. So from 7, you have an idea of where the maxilla should be. And again, by using the little rulers, such as the one that I alluded to earlier, and I actually have this little packet here to show you how simple this is. If you know nothing else, just do some early screening using this ruler. This was developed by Dr. John Mew, and you put it from the incisor to the tip of the nose, and it will give you an indication of whether your upper jaw is in the wrong spot. And if your upper jaw is in the wrong spot, it has a roll-on effect on the lower jaw. So which malocclusion type had the worst sleep disordered breathing problems? It's the one on the bottom right, the BR. BR means both the maxilla and mandible are set back. Now, this is just looking at AP. If you add vertical to that, the kid who was maxillary deficient, mandibular deficient, and had a long face, that's what I would now like to call the class 4, or what they used to call adenoid face, and what we now know is biskeletal retrusive long. Okay? The kids who didn't have any problems were the bi-protrusive kids. In other words, both their maxilla and mandible were very far forward, and the more far forward you got it, the better the posterior airway. Does that make sense? The second problem, kids, were those who were 2B. 2B, which is where my cursor is the maxilla might be in a good spot, but it's a retrognathic mandible, all right? Or 3A, where the mandible might be okay, but the maxilla's back. So whether your maxilla's back on its own, or your mandible's back on its own, or both are back, they're the increased likelihoods of having these conditions. Another paper from Japan also agreeing with the conclusion there is a link to where the obstruction is and what type of facial morphology that kid would have. And as I said, CPAP is required, and as soon as I diagnosed these kids with sleep apnea, while I was doing their orthodontics and fixing their structural integrity, I couldn't just have them collapsing 10, 15, sometimes 20 times per hour. We put them straight on CPAP. And I thank Jim Papadopoulos, who's the pediatric respiratory physician I work with, for his help in all these sleep studies and helping me understand how to identify the problems. So in this paper by Professor Christian Gumino, who is really the godfather of sleep medicine, unfortunately he passed away last year, he showed that if you have continuous positive airway pressure in a growing child, you develop a mid-face hyperplasia because the upper jaw is restricted from growing forward. So if you look at this girl, in diagram B, a facial type looks like that 3A, which is that whole mandible is grown, but not the maxilla hasn't. So her treatment and the treatment we did on a lot of these 3A kids was to widen their jaw and use a face mask to bring it forward, which you can do at this age. And you can see we're able to get her off her CPAP and give her a true structural form to maintain her airway. And I think that is much better than long-term CPAP use. So again, paper after paper, this is a paper where they looked at CBCT in children. And what did they show? The kids who were mouth breathers versus nasal breathers, the kids who were nasal breathers had significantly greater pharyngeal airway dimensions, right? So it's chicken and egg scenario in that regard. So what we looked at with our ear, nose, and throat doctors, if there was obstruction, is where was the obstruction? And in kids, it could be right in the front of the nose, which is the septum, the turbinates, the back of the nose, which is the nasopharynx, where the adenoids are, behind the palate, called the velopharynx, which is again related to the maxilla being back, or a long soft palate. Then below the palate, in the area that dentists should be looking at, which is the back of the tongue, in the area of the oropharynx. And we saw that there are a number of factors that were contributing to these problems. So what we did is, after the ear, nose, and throat doctor had done whatever he needed to do, which included lingual phorectomies if they were needed, nasal sprays for kids with allergic rhinitis. The more severe kids actually had inferior turbinates removed, tonsils and adenoids, etc. Then I took over and I changed the jaw structure to what it should have been. So if they had a 3A, I widened the upper jaw and I brought it forward. If they were 2B, I brought the lower jaw forward. If they were both, I did combination therapy. And then after that, we did another sleep study, and we compared the data to their baseline study to their post-ear, nose, and throat study, and what we showed a much better improvement, right? So for instance, if child A only had ear, nose, and throat intervention and had an apneic index of 15 per hour, known as a RDI, we found that after their tonsils and adenoids were removed, that maybe dropped to 10. Still not ideal. After their orthodontics, we had a massive increase, and that 10 probably went down to 2. And then our last group, where these kids started using a myofunctional trainer, and there's many of them on the market, and all of them have the same deal, and that's to put the tongue on the palate with the lips together and force you to breathe through your nose. That maintained these muscles, right? And they're the kids who went back to being perfectly normal and apnea index of 0, which is where a kid should be. So, let's start by, what do you do as a dentist if this is exciting and you want to help your kids, and you understand now that a lot of your kids, you haven't been checking their airway, but you have certainly seen their malocclusion type. We'll start with this ABARES questionnaire, and I'll send you this as a Word document. Get every parent of these young kids to fill it out, and it's a way of assessing things such as excessive daytime sleepiness, whether they awake regularly during the night, how many hours of sleep do they get, do they snore? So it's a very good question. If those figures come back as high, then that alerts you that you may have to look a bit further on these kids, right? Just to summarize our protocol, I saw the kid for the malocclusion, and I sent it to my ear, nose, and throat doctor to check their airway. I then, when their airway was resolved, fixed their jaw problem. So the null hypothesis from my research with Linda Aronson was that the airway obstruction caused the malocclusion. And so I fixed the airway obstruction first, then the malocclusion. And as I said, that involved maxillary expansion and or protraction. It involved mandibular advancement or combination, depending on what the kid needed. So this is the malocclusion I'm talking about. The maxilla's back, the mandible's back, and the face is long. So biskeletal retrusive long face. That's known as a class 4. Now, the appliances we developed, as I said, were all non-compliance type appliances. So we used this as our major arch developer. Why did we use this? Because as you saw in that video, while I was expanding the jaw, I wanted the tongue to start learning to be up where it should be on the palate. because ultimately it's the tongue that's going to maintain that development. If I had to bring the jaw forward, I wanted to use a upper jaw forward. I want to use a mask that would not have a retrognathic effect on the lower jaw. So my good friend and colleague, Dwayne Drummond, who's an excellent orthodontist and also believes in early treatment, he developed a mask that didn't have a chin cup. So as a result, we didn't have the negativity of pulling the upper jaw forward while the lower jaw went back. Since that time, in our current protocol, we use a mask which is developed by Sandra Khan, who's an orthodontist in California. This Khan bow also has no negative effect on the chin. So you can see the upper jaw widens with my alpha appliance, and then I bring it forward with face mask. And you can see the difference in that kid's face. Her mid-face hyperplasia has improved, her airway has improved. Now, if I needed to, on a 2B or a class 4, after I'd felt the upper jaw, got it in the right spot, many times the lower jaw just followed, right? Because the airway improved. But other times it didn't, and what we had to do was push the jaw forward. And again, I did it with a non-bulky appliance, so the tongue space wasn't affected, and that's called a Mara appliance, developed by James Eckhart, also in California. So, big influence on the Californians. I mean, they the progressive state in your country. I'll leave that for you to think. But it seemed to be that Derek Nordstrom from California taught me how to use this expander. The face mask came from also the East Coast. This is Washington State. Dr. Khan, California. Dr. Eckhart, California, right? And then the Myobrace, which is what I use to retain all these changes as my long-term retainer. And I'm lucky to say that this appliance was researched and developed in Australia. But I'm not pushing one appliance over the other. If you use a Myobrace, or you use a Healthy Start appliance, or you use a Myomunchie, or you use one of the French oral screen appliances, they all kind of do the same thing. The important thing is they only work at night when the kid wears them. During the day, to exercise those muscles, the kids need to do myofunctional therapy. And again, from the wonderful state of California comes Joy Moeller, who's a dental hygienist who's put together a program for hygienists and speech therapists to learn good quality myofunctional therapy. So I won't bore you with cephalometrics. We have kind of an hour and we're nearly at the end of that. I just want to give you an overview of my study. And from this, if you're interested, literally every one of those topics is a 1-hour lecture, which you can download free of charge on my YouTube channel. So if you want to learn how to fit the alpha appliance and adjust it, I have a 1-hour lecture. How to protract the maxilla, 1-hour lecture. How to bring the mandible forward, 1-hour lecture. So how to diagnose cephalometrically, 1-hour lecture. So this is all available on a website, which is called teachable.com. And if you go to the prefix of that, it's called EODO, which is my lecture organization. It's called Excellence in Orthodontics and Dentofacial Orthopedics. So EODO.teachable.com. And that's where you get these free 1-hour videos. For the papers, just send me an email. Now, this is using CBCT as a pre-screening tool. And I thank my friend Juan Quintero, great orthodontist in the state of Florida, and Sean Carlson, two great orthodontists who brought the diagnosis. And a lot of you are probably using CBCT right now for various things, including implants. But look at the airway in these kids, because this gives you a 3-dimensional map. And you see the kid on the left, class 2, narrow palate, backward mandible. Look at the airway, it's in the red. After the orthopedic correction, where the maxilla is developed and the jaw's brought forward, look at that kid's airway. The parent gets impressed with this, but you don't have to show them this. They know that the kid's better because they're doing better at school, they're sleeping better, etc., etc. So doctors, I would love to spend more time with you, but I literally have to go to a conference today. So I'll leave you with this slide. Please keep in touch with me. I'm passionate about this, and I'm passionate in helping you to help the kids in your practice. So if you email me, if you missed any of that, just send me an email and say, hey, I listened to you on that podcast. I'd like to learn more. And I'll send you all the papers, all the slides, and I have hundreds of slides because I've lectured around the world on this topic. And then also, more importantly than that, a protocol, like what form to use, what appliance, when to use it, et cetera, et cetera. So thank Dr. Shah and his team again for the kind invitation. And as I said, if you have questions and you want the further information, just email me. I'm pretty good with my emails, and I have a very good PA who can send that information out to you. So thanks again. Enjoy the rest of your weekend.